from Tasc at the National Rural Health Resource Center. This is our November Tasc Virtual Knowledge Group call. Our topic today is Community Health Needs Assessments and Flex Programs. Today, chatting with us is Tracy Morton, the Director of Population Health and the Manager of the Tasc program. A couple of reminders as we get started. Please take a moment to complete the polling questions on the right side of your screen. And I'd like to draw people's attention to the top left of your screen above the attendee list. There's a little person with their hand raised, and if you click on the right side of that for options, you can raise your hand, you can agree, disagree, and step away. So if you have a question during the webinar and you don't want to unmute your line, you can raise your hand and ask a question. And that prompts the facilitator to find a nice stopping point and ask you to identify your question. You can also agree or disagree or just let everyone know that you're away. So if I look to ask you something and I notice that you stepped away, the entire webinar doesn't have to keep holding up for you. Again, today we have a couple other reminders. One reminder is that the PIMS deadline has been extended to November 7th. So please reach out to your project officer if you're still having issues with that. Otherwise, please make an effort to get those updated by November 7th. And your state flex profiles are due to be renewed or updated as we do every year by November 8th. Please let us know, reach out to someone here at TAC, Andy, Tracy, Nicole, myself, anyone with the Tasc team or task@ruralcenter.org if you have any questions regarding updating your state flex profile. I don't believe we have any other reminders. There are files to download, so the slides as well as other resources on the bottom left that I'm sure will get discussed during the webinar today. If there's no questions or other comments, I will let Tracy take it away and talk to us about Community Health Needs Assessments.
Great. Thanks, Caleb. Welcome, everybody, to the call. I really appreciate you taking the time to join us today. A reminder about what the purpose of the virtual knowledge groups are. I do have some kind of presentation-like material to share with you today. I want to make sure that we're all kind of on the same page. But really, these calls are supposed to be more of a discussion-based forum to hear about best practices, challenges that are happening within the FLEX program as you apply your work plan. So I really do encourage your interjection of comments, your questions, and your sharing of content and information and ideas and your different approaches. So like Caleb mentioned, you can unmute your line to participate, which is *2. You can type in the chat box, so sometimes it's a little painful to watch everybody type. And then you can also raise your hand, which again lets us know that cue that you have something to add too. But please do add. That's really the purpose of these calls, is to share our content with each other. So our organization, the National Rural Health Resource Center, again, we're a nonprofit organization if you're not familiar with us yet. And one of the major areas of work that we've been doing over the last almost 20 years now is working on community health related content, and particularly doing community health needs assessments as a service that we provide. So we have a lot of foundational information and knowledge to share about community health needs assessments, how they've evolved over time, and what some legislation did and how that affected not only how our critical access hospitals or our nonprofit hospitals around the country are reacting to community health needs assessments, but also how our FLEX programs are changed their approach too. So that's some content that I wanted to be sure to share with you today. So again, as Caleb mentioned, the purpose today is really to understand the importance of the community health needs assessments, or CHNAs. You'll also sometimes hear them called CHINAs, in meeting the health needs of a community and then discussing how your programs might be working on it. So it's kind of a question for everybody as we get going. Andy just pulled up a polling question there on the right. How familiar are you with the Internal Revenue Service, or the IRS requirements for community health needs assessments? You can just take a minute and answer that question. Okay, great. So it looks like we have, most people are either moderately or slightly familiar or even unfamiliar with what that content is. So that's helpful just to know as we move forward here today. So community health needs assessments have long existed before legislation came into play that impacted hospitals with the Internal Revenue Service requirements. And community health needs assessments have lots of different purposes, and lots of different organizations actually conduct community health needs assessments. You can see some of the purposes listed here on the screen most clearly, and obviously they're about identifying community needs, but then they can help do some other things too, like capture future market share of an organization, inform a strategic plan or adapt a vision or a mission for an organization, improve coordination of services, both within the entity or the organization that's conducting that community health needs assessment, but also community-wide, and of course, demonstrating impact. But there's lots of different organizations that do it. So often in Flex, we're thinking about our hospitals, in particular our critical access hospitals, but there's other groups that do community health needs assessments too. Public health departments do community health assessments, sometimes called CHAs, which might be where you hear the China term as well. They also do community health improvement plans, which are a similar type of thing, and other organizations can do them as well. So again, another polling question on the side. CHs were completing community health needs assessments before they were required by the IRS. Just a kind of quick gauge, a true or false question there for folks to respond to. Okay, great. So yeah, a lot of critical access hospitals or other types of hospitals, rural or urban-based, were doing community health needs assessments long before they were required by their Internal Revenue Service for all those purposes on the left side. And they really help a hospital to understand the foundation of the services they're providing, whether or not they're meeting the community's need or exceeding their need, in which case they may need to eliminate some services. So it's really a touch point to understand what the community is looking at, and it can be a very forward-facing document and effort to tell the community that you are listening and you are responding to them and adjusting to them. So they have existed before the IRS requirements came along. So what happened was that community health needs assessments, though, got adjusted in the Patient Protection and Affordable Care Act of 2010. And so what that said was that nonprofit hospitals, whatever type of hospital you were, but nonprofit hospitals, are required to demonstrate the community benefit status to the Internal Revenue Service every 3 years by conducting a community health needs assessment, really to be able to maintain that that nonprofit status. So it's a way for them to demonstrate that community benefit to maintain that tax-exempt status within nonprofit. So for-profit hospitals, district-owned hospitals are not required to complete a community health needs assessment, but it's still really highly recommended, and we still see a lot of hospitals actually still conducting them because of all those purposes that I explained just before. So there are some requirements, and I have the link there in the bottom for the source for this, but there are some requirements that their Internal Revenue Service laid out for meeting these community health needs assessments. Generally speaking, they have to define the community that they're serving, they have to assess the health needs, they have to solicit different input, but that has to include special knowledge or expertise of those that are in public health. They have to document the CHNA in a written report, and it has to be relevant to that particular facility, so they can't just necessarily take someone else's CHNA that has been conducted, say, by another organization and make it their own. They have to make sure that they adopt it to theirs. And it needs to be authorized by a representative of the hospital facility that it is truly their CHNA report. And they have to make it widely available to the public. So that includes linking it to the hospital's website, and also if someone requests it, say Joe Public requests, I'd like a copy of that, they have to be able to print it and get that individual a true paper copy. So they have some different steps that they have to do then to meet that, but the interpretation of how those steps occurs can be different. So I'm wondering In your experience, how often have you struggled to find a community health needs assessment report for the critical access hospitals on their websites? So a lot of state flex programs have kind of probably dug around for those, for your needs assessments, or even for specific activities in the flex program. And I'm just wondering, how often do you struggle to find those reports? So the individuals that said that they rarely struggle to find them, I think you're pretty lucky. We had the similar experience here where, you know, sometimes or quite often we're having a hard time finding the CHNAs in that public domain on the website. And one part is that, generally speaking, critical access hospital websites are pretty awful. They're not regularly maintained. They aren't easy to navigate. And we all have our own struggles with all of our own organizational websites. But this is, you know, a marketing piece out to their community that's really showcasing the work that they're doing. And this can very simply just be a quick link on their landing page. So this is an opportunity for sure, but it definitely can be a challenge to all of us as well, too, as we're trying to find the content that might be describing what it is that this hospital did and the approach that they took. So as I mentioned before, the way that these various different steps are implemented, there's a lot more detail that are laid out in the IRS requirements, but there's still a lot of subject for interpretation, which could be a very good thing, but also can be really challenging too. So I'm going to explain a little bit more about some opportunities about how the methods for conducting the community health needs assessment might be conducted. So there's a component of the CHNA where you need to solicit or take into account the perspective of the community, and that needs to represent broad interests. So things to note is that this needs to include information that might come from state, tribal, local representatives, and that also might come from the public health services in the area. The community input needs to adequately represent members of medically underserved, low-income minority populations as well that the community might be serving or that the hospital might be serving. And then it has to have written comments as well that are available for those to review and part of their implementation strategy. Some of the shortfalls that we see as an organization within this opportunity for collecting community input is that a hospital may be relying solely on secondary data, and I'll talk in a minute about what I mean by secondary data, but they might be relying on data that's been collected by a different entity. And that data can be really fantastic, or it could meet maybe that second bullet down about representing those that are medically underserved, low-income minority populations because of how that secondary data was collected. So just an example there and something to think about when you're looking at the reports from the hospitals in your state is, you know, are they really truly getting the full picture? And that actually can be a challenge too when, say, our organization, one of the methods that we use for community health needs assessments is doing a mailed survey. And if you have a transient population in the area or those that are have some different cultural beliefs about responding to surveys or distrust with the facility, they're going to be less likely maybe to respond to something like a mailed community survey. So sometimes different approaches need to be done to reach different populations too. There are different ways to gather that community input in the community health needs assessment, and there's a variety of different approaches. None of these are necessarily deemed wrong or right by the Internal Revenue Service. They just need to be representative. So the primary data is kind of really collecting that original new information. So when you, as a state flex program, reach out, say, with a survey to all your community health needs or your critical access hospitals about their needs for MB-QIP reporting, the way that you're collecting those responses and information back, that's primary data. You're directly facilitating the aggregation of that new information. So there's lots of different ways that a CHNA can collect primary data. They can do it through a survey, be it mailed or electronic. They can hold focus groups, town hall meetings, key informants, lots of different ways to do that. Secondary data, like I mentioned before, is a really common approach for collecting information, and that's using information that's really been collected for some other purpose. So some things that we in the Flex world might be familiar with are just data that exists through our state public health department, through our state office of rural health, through something like county health rankings, which I think a lot of you are aware of. The Centers for Disease Control and Prevention has tons of different data sets, local public health, or even local surveys. For example, here in the Duluth area, there's a great mailed survey and telephone survey that goes out called Bridge to Health, which is really helpful because it collects very specific behavioral type information for this kind of 4-county region here. So that's really great, but it's a secondary data source that we need to use. And the catch-22 with all secondary data, actually with any data collection in any purpose, is understanding the methods with which it was collected because of things I just mentioned before, how it could underrepresent or overrepresent certain parts of the population. So just something to look at and take into consideration when you're looking at the CHNAs that have been conducted by the facilities in your state. One of the other and kind of the final parts of the community health needs assessment is after they get all this great information, the hospital really needs to develop an implementation strategy. So what we often see with the community health needs assessment is they have this great report of all the health findings in their state or in the area, and they have the needs identified, but then there's nothing on the website that says what they're going to do to address those needs. And that's the implementation strategy. That's part of the IRS requirements. And it has to be a written plan. And again, we don't see this very often. It's kind of an item that might be skipped, and we also know just through conversations with different facilities that this is something where they had the best intentions about addressing those 3 needs that they identified, and then 3 years come along and they haven't really had any chance to, or made the chance, excuse me, to actually do anything to address those needs for all different types of reasons and intentions. So this is an area where hospitals often fall short, is not only describing what their implementation strategy is to the identified needs, but also actually making the rubber hit the road and doing something about it. So those are some opportunities for Flex, and we'll talk about that. The one other thing, too, is just an awareness piece, that in the Community Health Needs Assessment report, when the hospital, say, identifies their top 5 needs and they choose in their implementation strategy because of resources or whatever it means, maybe, to address only 2 of those needs, they need to describe what they are not addressing and why not. And so they just need to be able to provide a reason for not addressing those other items, be it that it's being addressed by a different organization, resources, et cetera, but they can't just not mention why they're not doing something about it. And if you're looking for more information about what the IRS requirements are, here's a link to that. And again, like Kayla mentioned before, in the file section of the bottom left corner of the screen, you can download this presentation and have access to these hyperlinks as well. So community health needs assessments actually used to, at one point in time, be an allowed activity within the state Flex program. So you, in your Flex work plan, could write in that you were going to directly support, say, a subcontractor to conduct community health needs assessments on behalf of the critical access hospitals in your state. However, after the Affordable Care Act came out, the Federal Office of Rural Health Policy discontinued allowing Flex or federal dollars to pay for CHs, essentially to meet a federal requirement too. So that part was removed out of it, and certainly makes sense. And now we have some different things that we can do in the Flex program to support community health needs assessments, but not necessarily pay for an entity to conduct a community health needs assessments on behalf of the hospitals to meet their requirements. So a little bit about what the activity categories are that are in the current year's Flex program. So this all falls into Program Area 3 about population health improvement. And the goal within this area is really to build that capacity for the CHs to achieve improvement on particular health outcomes. So the first activity is then about supporting the CHs to identify community and resource needs. So this is really that planning and assessment part, looking to target interventions then for activity categories 3.2 and 3.3. And so what you can do here in this area is you can support your critical access hospitals with other organizations that they might need, tools and resources to really help them identify their strengths and their needs within their communities, helping them to find data sources to support understanding what the needs are, understanding what the requirements are for CH&Es and offering trainings, helping them to identify best practices for the CH&A process and that implementation planning. You can also, and probably should be, tracking CH&A completion and monitoring what those findings are. Again, you need that kind of as part of your needs assessment for your FLEX program anyway. And then guiding through them through the process of the CH&A if you have internal expertise. So again, you can't necessarily pay for a subcontractor to aid a community critical access hospital in conducting their CH&A, but if you have internal expertise within your state FLEX program, or you can get some in-kind support to be able to guide them through this process, that is an allowed thing. So activity 3.2 then kind of moves that into more application. So this is about assisting the CHS to build strategies to then prioritize and address those needs that are identified. So what you are doing here is kind of maybe supporting a cohort, you're sharing tools and resources, you're facilitating action planning. And again, this facilitates the hospitals really doing something with their implementation plans versus just having that documentation there. You might be helping with the community collaboration and supporting some subject matter experts to maybe provide particular insight on topics. So say, for example, in a cohort of critical access hospitals, mental and behavioral health among teenagers was really a top issue. You could be providing then subject matter expertise to a cohort to address that particular topic. And then activity 3.3 is it's kind of similar to 3.2, but it's really about implementing very specific activities to improve health with a focus on sustainability of that activity beyond those FLEX-supported years of the project, too. So Andy's popped up the next polling question. I'm just curious of those that are on the call here today. Which of any of these activity categories is your FLEX program working on in any of the years of this kind of 5-year cycle that we've now entered into? Give you a couple more minutes to finish that. I realize you might be looking back and forth between what the numbers are and what their descriptions are. Okay, great. So it looks like there's quite a few states that are helping their CHs kind of identify those needs. A handful of you are working to help the CHs really identify those strategies, and then a group are also working on very particular items that might be engaging those community stakeholders and those experts to really address those particular needs. So that's actually what the latter part here now of the call is going to be about, is kind of hearing some different examples from state FLEX programs about what it is that you're doing within these different activities based on what we've seen with the work with the community health needs assessments in your state over the last iteration of the FLEX program cycle, kind of what you've planned out for the next year going forward. So I've kind of pre-identified a couple different states that I know are doing work in this area, but really I want to open this up to everybody to kind of share what they have going on and ask questions of each other. So please do, like we said before, use *2 to unmute your line. You can type in the chat box if you'd like, or you certainly can raise your hand and we'll be sure to see you there. So with that, I'd like to invite Laura Brooks from the Oklahoma State Office of Rural Health they've had some longstanding efforts in their state to support their hospitals with the community health needs assessment process. So Laura's going to talk about what that is that they do there and a little bit of some of their stumbling blocks as well, too. So welcome, Laura. It's really great to have you on today. Thank you.
Hi, can you hear me okay?
Sure can.
Okay, now what do I do to advance my slides?
I'm sorry. Yep, there's some arrows there on the, there you go. Yep, you're good.
Okay, cool. Well, thank you guys for having us. So I just have about 4 slides, and it's really just to keep me on track so I don't ramble. But the Oklahoma Office of Rural Health, so we facilitate the community health needs assessment for quite a few hospitals in our state. We do not charge the facilities, but we also do not pay a vendor. This is all done in-house. We actually, prior to the Affordable Care Act, we did the community health engagement process, which was really looking at data, getting the hospital and community together to kind of talk. You know, what does the community need? What's the perception? And then the hospitals kind of respond and make modifications. With the passage of the Affordable Care Act, we took what we were doing but added in a few extra steps to get to identifying, you know, health needs and then prioritizing those health needs. And then also documenting everything into a comprehensive report along with an implementation strategy. Tracy, just to kind of follow up on one of your slides, the hospitals having this posted on their individual websites is actually a really big deal from the IRS, from what we're hearing from some of our hospitals. We've actually had some hospitals audited because the IRS person could not find it on their website, so that's spurred an in-person audit. And the IRS is wanting to see at least 2 needs assessments on the website too, so the current one and then the previous 3-year cycle needs assessment. So now I'm off track. So overall, we conduct about, on average, 10 needs assessments every year. Obviously, during the 3-year cycle, we do more. But next year, for example, we shouldn't be doing hardly any for the IRS requirement, but we're still on track to have 10 scheduled out during next year. We also work with facilities who are not required by the IRS to do a needs assessment. I would say about a quarter to a third of the ones that we complete are really just folks wanting the information, wanting the engagement, and to hear from the community. Our process, kind of talking about the data, overall we do 3 community meetings. We present secondary data. We also do a community survey and present those results. But we present it to a room of community members kind of in a roundtable fashion. So we present data, but then turn it over and ask for kind of a list from each group of what are their health concerns. The end of the 3rd meeting, our goal is to leave there with the priorities identified by folks in the room. We believe it's very important that the stakeholders in the room identify the priorities, so then they have ownership in what they want to work on. Let's see. So some of the trends that we see, mental health and everything around mental health is something that comes up in almost every community that we've worked in for quite a while. Obesity, and then kind of linking that to like nutrition education, the importance of a healthy lifestyle are also big items that are talked about. Access to primary care, and then also the importance of prevention services and just preventative care. We internally use what we're hearing to kind of guide us in developing resources, but also making contacts and placing those hospitals in contact with folks where this is really their specialty. I did add in a bullet point here for added benefits of completing the needs assessments. We do them because, well, they're fun, but it's a great community building activity. But also, an example, a couple of years ago, we worked with a hospital that prior to that, we really didn't have that great of contact with that hospital. They've been a critical access hospital for quite a while, but they didn't really respond to our emails that well. They participated, I think, in one domain of NBQIP. They were just hard to reach. And we did a site visit about 2.5 years ago, and they mentioned they wanted to do a needs assessment. And so we're like, okay, yeah, let's do that. And since then, they're our friends. Like we're in good contact with them, and actually, if my spreadsheet's right, I should not have to do an MB-Quib waiver with them next year. So it's really helped us build that relationship with that hospital too. Our next steps. So now we get to my part where I lament. The struggle with the implementation strategies. It is a requirement that each hospital, if you have to do a needs assessment, you have to have an implementation strategy, and those have to be posted on your website. We document the report for everyone, all the hospitals. Really, what we've struggled with is where our role ends in this process. Like I mentioned, identifying priorities. We want the hospitals and the communities to own the priorities, but we also want them to own the implementation too, because that's how they move on to do bigger and bigger and better things. In the past, we've always been more than willing to place a hospital or community in touch with a resource or make that connection, but really kind of where that ends has been our struggle. We are in the process. We're actually tomorrow will be our last webinar, but we're doing a webinar series with Ide Bailey. It's a 3-part series where the first one was just going over what are the requirements step by step, what does the IRS want to see, what do you need to be doing, and the importance of doing it right. The second webinar was what are some of the added benefits as a hospital completing a needs assessment, getting some of those extra tidbits of why patients aren't your patients or how to get those folks to be your patients. And then our webinar tomorrow, we have 2 folks talking about just some implementation items that are they could be replicated in another community. So just kind of to keep that ball rolling. Website updates. So we also post the needs assessments we complete on our website. It still needs to be on the hospital website, but just making our website better, I guess a more, I wouldn't say user-friendly, but just prettier and easier to access. I know a couple other states, Montana and Oregon, come to the top of my mind of states that do a really good job of showcasing needs assessments. And then an annual summary report. 9 years after the passage of the Affordable Care Act, this sounds like a good idea now. We have a lot of internal folks who are asking about, well, what's coming up in the needs assessment? And generally, we do, just like I did in that previous slide, mental health, obesity, items such as that. But now we're starting to have some external folks wanting to use the needs assessments to kind of guide some other discussions. And the researcher in me is like, well, these aren't necessarily apples to apples. Each needs assessment is not exactly the same. And so we're going to start doing an annual report to kind of lay out who all we worked with that year, who was at the table, what kind of, if their process was a little bit different than the other one, kind of outlining that, and then summarizing what we heard in each community. And that is all I had for slides.
That's great, Laura. So does anybody have any questions for Laura about their process or how they've been supporting the hospitals? Again, star 2 to unmute, or you can type in the chat or raise your hand, whatever works.
I have a question for folks.
Yeah, go ahead.
So we try to partner with the State Department of Health as much as we can. It's usually best, when our years align. But does anyone else partner with your community action agencies? We have once, but it seems like they're doing needs assessments every 3 years.
Anybody doing that? So Kyle Cameron's in Wyoming, saying that they use the community service block grant. If you're typing, I really encourage you to press star 2 and unmute your line. I promise it's not scary, and it will move the conversation a little bit more fluidly.
Tracy, are you aware of anyone else doing kind of unique partnerships to complete needs assessments?
There are some one-off ones that I can think of that are going on around the country, but nothing that I can think of that comes to mind as a a complete region or a state doing it, but that might just be that I'm not aware of it. We can dig into that a little bit more, though, and I think get back to you on that. I also was working on the question for actually the Minnesota Flex program about examples where the community health needs assessments, kind of similar to what you're asking, are though partnering with local public health to complete their assessment. So public health departments that are seeking accreditation need to do a community health assessment and a community health improvement plan every 5 years on a cycle. And so there are examples around both in urban and rural environments where facilities may be coming together with their local health departments to complete those assessments. And often what happens is that the local health department is following then just the 3-year cycle instead of the 5-year cycle, so they align, but that does require more resources kind of dedicated from that local health department, at least more frequently to do so. So we see that a lot, or I've seen more examples of that in urban environments where they actually probably have more dedicated staff to actually completing something like this, where in our local areas we may not even actually have local public health except for maybe a nurse whose major roles are actually maybe more immunization and WIC related. So, but we can look for other examples and kind of share those out as well. Okay, so thanks, Laura, for your time. I appreciate it. Maybe now if we want to switch over to, I know Sarah Morin is on the call from Michigan, and I know that you're doing this work in Michigan too, Sarah. So you want to explain a little bit about what you guys have been up to there? Again, *2 to unmute your line.
Hey, Tracy, can you hear me?
Yes, I can.
Perfect, thank you. So yes, in Michigan we are doing a little bit of this work, and we have been for a couple of years now. So initially we did work with a student out of Michigan State University, and a Master's of Public Health student, and they compiled all of the community health needs assessments across the state, the rural ones, not just the critical access, but the other nonprofit rural hospitals as well. So after they kind of pulled all of them together, they did analyze them both by geographic region and then by the commonality of the needs that are identified in those assessments. So a few things, kind of challenges that we found with that report, again, probably nothing earth-shattering if you've been in the community health needs assessment realm at all, and I think Tracy touched on these a bit. So we did first find that there's a very wide variance in the quality of the community health needs assessments, across the state. So some hospitals, of course, just kind of go through the IRS requirements, kind of just check the box and get it done, maybe put it on the shelf somewhere, while others do really use it to strategically inform the decisions that their hospitals are implementing for the next couple of years. And, as Tracy went over the IRS requirements, yes, there are requirements surrounding the CHNA process, but they are still fairly vague, kind of up for interpretation in some elements. So even among the hospitals that did kind of take a deep dive in an analytical approach to their community health needs assessments, we realized that when we analyzed them, that we really weren't comparing apples to apples. Even when looking in specific geographic regions with neighboring facilities, some of them weren't identifying common themes. And, one of the questions we asked is that, are they not identifying common themes because they're not asking the same questions, they're not implementing the same process for identifying needs, or are the needs actually that varied even among neighboring facilities? So there is a region in Michigan, it's affectionately called the thumb. If you look at the shape of Michigan, it outlines a hand, a mitten, and the thumb hospitals are very close in proximity, and they do work collaboratively on a number of other initiatives. So they came together along with their local public health agencies. There was some additional grant funding through the public health department at that time, and they determined a common survey process and templates for their needs assessments and implemented the same kind of templates for the 8 community health needs assessments for those hospitals. So they did find that, not surprising, the cost of health insurance, the cost of medications for seniors were both top concerns for their community, along with cancer being a top health concern. And then they also identified major barriers to accessing adequate health care, shortage of specialists and primary care providers within the region, which again, isn't shocking in terms of what we know from other data sources. And then their top economic challenge was a lack of jobs with livable wages. So it was really a regional approach to this community health needs assessment, so that was great to see all of those hospitals kind of comparing apples to apples at that time. So we were happy to have helped them move that forward. And then another kind of common approach we saw was from that analysis report of all of the community health needs assessments across the state, we identified that the critical access hospitals in the eastern upper peninsula of Michigan had a common theme of mental and behavioral health access issues. So we did hold a meeting pulling together those two critical access hospitals along with the PPS hospital that was in their region, who has an inpatient behavioral health facility. Also tapped the local public health department, community mental health agencies, law enforcement, school systems, and other community partners that were identified. And we provided them with a platform to network, share best practices, and provide some peer education. We brought a small amount of funding and allowed the critical access hospitals to apply for some of the funding that they felt appropriate for their individual facilities. So we did, through that kind of common platform for them, decided that it wasn't just implementing one specific program or initiative in that region. It really needed to be tailored to the individual facilities. So we allowed them to pick what that project was. And they applied for things such as staff and education training, telehealth equipment, and one facility did creatively use it to help to hire an LMSW that they then integrated into their primary care clinics. So we do have a couple of regions in the state that are starting to take a collaborative approach to community health needs assessments, but we still have a ways to go in terms of getting that statewide or even getting other geographic kind of pockets to follow suit.
Thanks for sharing, Sarah. I like how, you guys did, exactly what can happen with activity 3.2 and 3.3 beyond that last year in the grant then with identifying that regional thing. And I think that's what we hear of a lot, as an organization when we're out helping communities, do their community health needs assessment, and then particularly when we get to the part about implementation planning, they're always looking for examples of who else is doing something. And when it's a facility that you're more familiar with or something within your state or your region too, they're often more open to working with those groups too. So that's a really neat approach. Questions at all for Sarah about what they're doing in Michigan or plans moving forward? Okay. All right. Thanks, Sarah.
Yep. Thanks, Tracy.
And lastly, I kind of queued up then Jill and Brenna in Arizona to share about what it is that they're doing there and plans for this next year with the Flex grant as well. So welcome, Jill and Brenna.
I'm going to let Brenna speak.
Hi, everybody. This is Brenna. Can you hear me okay?
Yep. Yes, I can.
Excellent. So here in Arizona, we've taken some similar steps as Michigan and Oklahoma. But basically, in prior years, we have developed an assessment and synthesis tool that we use to review all of our community health needs assessments that are completed by our cause. And we, in Arizona, I should qualify that we have about 10 critical access hospitals that are required to do the community health needs assessment. So we're working with a small pool, although we have a couple new cause joining us last year, and I think we'll have one in the next year or two. So we'll have a slightly bigger pool, but we are working with a small number of cause. So it makes it pretty straightforward for us to synthesize and review their CHNAs. So we basically made our own checklist to assess both the quality of the CHNA process, including what was the data collection procedures, what was the quality of the data used, and we used evidence-based toolkits from places like the American Hospital Association, the Catholic Health Association, NACHO, the Public Health Institute, and Rural Health Works to create kind of our own synthesis checklist to review those CHNAs. And basically what we looked for, in addition to, what is the kind of overall quality of the process being implemented, so that was really done to help us identify where there might be challenges that we could support our critical access hospitals in gathering data or analyzing data. That tended to be the biggest challenge area, along with developing strategies to address health priorities. We also wanted to identify what were the shared health priorities across our critical access hospitals. And then with those shared priorities, basically, at this point, we haven't helped any of our critical access hospitals do any implementation activities. But what we're doing is trying to connect them and link them into other events, training, and resources that are happening across the state. And so what we found is we did have a good amount of overlap between our critical access hospitals and their shared health priorities. So what we found was access to care was the number one health priority in common across our hospitals, followed by behavioral health, chronic disease conditions related to a healthy lifestyle, and then needs of an aging population. And to understand how our critical access hospitals' health priorities lined up or didn't line up with the state health priorities, we compared across individual cause to the state health priorities. And what we found was that access to care, behavioral health issues, and healthy lifestyle issues were shared between our critical access hospitals and the state health improvement plan. The one area, that was different between our critical access hospitals and the state health plan was needs of an aging population. So what that really identified for us was that our critical access hospitals are serving, as the demographics would suggest, an older population, and they really were looking for support for senior and home health, for behavioral health needs specific to older populations, and with assistance in getting specialized care for dementia and other age-related health conditions. So that was the results of our synthesis and analysis that we did, I think, in 2017. And what we'll be doing this year is we'll be updating that analysis, reviewing, I think we have about 3 or 4 critical access hospitals that will have a new community health needs assessment that will be due in the coming year. So we'll be reviewing those and using the same checklist type approach. And then, again, help seeing where the priorities of our critical access hospitals either meet or either line up or don't line up with the state health improvement plan. But one big area that we used our CHNA analysis to support was we've employed 2 part-time, at least on Flex, part-time community outreach and health educators. And they serve regionally, one in southern Arizona and one in northern Arizona. And their role is really kind of centered around population and community health. And they really serve in like a connecting capacity in order to link our critical access hospitals to programs, trainings, resources, and coalitions in the state that might be doing work in the areas that our critical access hospitals identified as one of their health priorities. So one of the biggest areas that they work in right now is linking our cause to all of the behavioral health and substance misuse and abuse work going on in the state. The other area they work in that was a health priority for our critical access hospitals is access to health care, particularly via health insurance enrollment. So both our health educators are certified assisters and work in our CAW communities to enroll people in marketplace health insurance as well as the state Medicaid program. So that's kind of an overview of what we're doing in Arizona.
I just want to add one thing to Brenna's, is that our health educators also work on other programs at the Center for Rural Health here. And really know how to connect the communities to all of the programs that are going on because they're involved in not just Flex, but they're really involved in all of the programs under the center, which is really helps them connect the communities to many, many services.
Excellent. Thanks, Bruna and Jill. I personally really like your systematic approach kind of evaluating what was all in those CHNAs and also the quality of them too, so you can know where to provide technical support too. Any questions at all for Bruna and Jill?
Hi, this is Lima from Nevada. And I have a question about the definition really of access to care. Because when we in Nevada do our, we provided technical assistance to our costs to administer community health needs assessments. And all of our costs, but pretty much using the same question set. Sometimes they add, sometimes they add questions that are related more to their facility. But with access of care, I always notice, there's a really big difference between lack of physicians or lack of services, or we also have some community, a lot of community members that are older. They have actually difficulty access of care to non-emergency medical services that are just simple appointments to the doctors, how to get there. Thank you.
That's a great question, Lima. One of the things that we've seen too, even in the surveys that we conduct here at the center, is just about that and some responses that come back. And also one of the other kind of trends that we're starting to see with some of the facilities we've been working with is access about extended hours. So whether or not, if the facility outpatient services all close up at 5 p.m., that means people are likely to present to the emergency department, or if they're aware of what their insurance costs would be, maybe are not likely to present to the emergency department too. And so we're seeing some different access responses too. And sometimes the responses that we get back on those surveys can be really jumbled up if the question isn't worded right, because it can be all those things that you just mentioned about provider access, access to different specialty type services, access to the time of day that works, or transportation, or a variety of other things too. So that specificity is really, really important. And also I think another thing too that we see as well is just people aren't generally in communities, the public is not well aware of the services maybe that the facility provides, and that's just a marketing communication type piece that can greatly be revealed with the community health needs assessment, because people might say that they don't have access to, say, a gerontologist or a nutritionist or whatever too, and the facility does offer that. They're just not advertising it well.
Yes, we noticed that in Nevada, in a lot of rural hospitals, they do have sometimes the list on the door what their services are, but sometimes it doesn't really get further into community. That's a big problem. Oh, thank you.
Thank you. Anyone else have any questions, or is there another state that wants to share one of the activities that they have planned in the Flex grant for this coming year? I'd be really curious to hear from a state that maybe has a specific health condition that they're working to address, kind of like how Michigan is particularly doing that work about mental behavioral health. If you have, say, a diabetes project or whatever it is there anybody on the line that has something specific that they're doing that they found from the CHNAs?
Hi, this is Jen from Pennsylvania. We are actually working with our hospitals, our critical access hospitals, to assist them with targeting COPD type initiatives in, establishing respiratory therapy and those kinds of things.
Very cool. So how did you guys land on that topic?
So, the Pennsylvania rural health model, the first 5 hospitals that are participating in that, 3 of them are critical access hospitals, and when they not only get global payments, but they have to build transformation plans so that they can, transform and target population health initiatives. And all 5 of those hospitals indicated that that was something that their community needed and was interested in writing that into their transformation plans. So we wanted to help the critical access hospitals implement their transformation plans. So still working with them on exactly how we're going to do that.
Well, that's great, and I think that's a project that we'd be, uniquely interested here in Tasc about. I'm sure Caleb's ears perked up there with the work that we did last year with that supplement to support the COPD-related content. So please do keep us informed about that.
Yeah, we were very attentive to Caleb's, all of the resources that you guys put out on that, and we send those out all the time. Listen to the rural radio podcasts and all of that.
Great.
Excellent. Great. We have a few more minutes left. Anybody else want to share what they might be up to this year for their Flex grant activities related to CHNAs or a population health type project?
Tracy, this is Jill Bullock. I have a comment, and it came out of their CHNA. Is a hospital in Arizona, Critical Access Hospital, wants to begin a wellness program around obesity and diabetes in their hospital using their what do you call it when you're their machines, I'm blanking out, when they go to physical therapy and using those machines to help with diet and exercise, but they have the question of, does another hospital have such a program like that, and can you bill for something like that?
That's a very good question. We can look into that for you for sure. If you want to send us, could you send me a follow-up email so I know specifically what maybe machines you're looking for? Otherwise, we can poke around too and find that.
They've got their equipment for physical therapy, okay. So they've got the equipment there. But yes, I'll send you a follow-up email.
Yeah, we can definitely look into that. That's a good question. Okay. Well, we're getting close to the top of the hour. I just wanted to thank everybody for sharing today, too. I think that the program area and the Flex grant, personally, I feel like is really gives a lot of latitude for the things that we can do, but I hope today that you saw that there's some opportunities for you as a Flex program to really become familiar with the requirements of the community health needs assessments from the Internal Revenue Service, but also kind of understanding to what constitutes a really well thought out community health needs assessment plan and approach, so that you can provide some technical assistance, or you can always reach out to us, or there's a number of different organizations that support this work, including those on the public health side, like NACHO and things like that. But there's also the opportunity for you as a Flex program to help the programs understand what constitutes good data for them too. And if you're interested in that a little bit more, there's a Task 90 coming up. You can see the date for that in the bottom corner, but it's next Wednesday. We'll be talking about population health, and I'll share some resources for you about finding some good data. But really, I'd like hearing from the different states today. Thank you so much for sharing, because really what you're doing as your programs is you're tying the hospitals to resources, to different other hospitals that might be doing similar work and kind of creating those cohorts. And what you're really doing is that you're helping the hospitals for their communities demonstrate the need to the community of the hospital and what their services are that the hospital can provide to them. You're helping them to identify service line gaps and really to create that impact within the community, update their strategies for the hospital overall, and really helping that hospital, and you can do this, to understand how meeting this requirement really helps position that hospital into population health management in the future and into transitioning to a model